Hi, Dr. Giri.
Hello.
Hi, how are you?
Good. Okay, so can you allow me to share screen,
Yeah,
Akanksha?
sure. Yeah, sure. Yeah.
Okay, so I think we are here, right?
Yes.
Should we wait for a little bit?
Yeah, I wonder I should message people to start joining.
Yeah.
How are you doing?
Yeah, I'm doing great. Yeah.
Where are you from?
Oh, I grew up in Gujarat, but I
Gujarat.
was born in Indore, Madhya Pradesh.
Ah,
So my parents moved to Gujarat when I was like 2 years old. So
nice.
you know, I grew up in various towns in Gujarat. So
Nice. My husband is from Madhya Pradesh too.
oh, is it? Yeah.
Yeah.
Which city?
He's from Jabalpur. He's in,
Oh, okay. Yeah,
I
I
don't
have
know.
never been to Jabalpur. I am
Yeah,
from the Madhya Bharat. The
yeah.
Indore, Devas. And you are from which?
I am from Nagpur.
Oh, Nagpur. Mhm.
Yeah. Born and brought up in Nagpur. My MBBS was GMC Nagpur, MD.
Yeah, Nagpur is used like it is very Hindi influenced part of Maharashtra.
Yes, it is. Yes.
My brother worked in Nagpur for some years. So once I went, I've been to Nagpur once some years
Oh,
ago.
yeah. Nagpur is a good size city. It's
Yeah,
nice and
yeah,
silent in there.
yeah.
Yeah.
Orange City.
Oh yeah, Orange City. You should come to Nagpur. I will have orange burfi for you. All right. I guess we can get started and start recording, and people will keep on joining.
Oh, okay.
Yeah.
So I was just thinking that, since I'm seeing on the screen Phyllodes tumor, so let's see if we have some more examples of that and we can talk. And I've brought one of my PowerPoint presentation. We'll see if we
Mm-hmm.
uh, have that. Oh, okay. So there are a number of cases here of Phyllodes tumor. So
Nice.
let's talk. Uh, so Phyllodes tumor is
I just
rather an
finished the last
uncommon
piece there,
fibroepithelial
and then
lesion,
went through
especially
most of it.
when was there something?
No, there was someone who didn't mute themselves. Please go ahead.
Oh, okay, that's fine. Yeah, so I mean, obviously, in comparison with fibroadenoma, Phyllodes tumor is quite rare. Uh, but from time to time, this presents like a dilemma or even sometimes a problem of diagnosis. So I think it would be worthwhile having some discussion about this entity. So here is a core biopsy of a rather cellular appearing fibroepithelial lesion. So when you see this degree of cellularity, then you start wondering whether this is, can I call this fibroadenoma, or whether I should call it Phyllodes tumor, or should I just call it fibroepithelial lesion? So, I mean, obviously in this case, apart from the high degree of cellularity, we can also see some evidence of fat being entrapped. So this appears to be somewhat of an infiltrative lesion. Even here, when you go to the periphery of the biopsy, at the interface of the parenchyma and the lesion itself, you can see that the lesion is attempting to incorporate fat. So it certainly is showing some evidence of infiltrative characteristics. So if in a core biopsy you see something like that, then it probably it is not a fibroadenoma. It's sometimes difficult in a core biopsy to decide whether you are dealing with a fibroadenoma or a Phyllodes tumor. So I think some years ago there was a study that looked at at this question of what are the features that will allow you to distinguish a fibroadenoma from a Phyllodes tumor on core biopsy. So one of the things they obviously pointed out was that if you see infiltrative characteristics, then it probably is not a fibroadenoma. One of the other things that they pointed out in that paper, that was an interesting paper actually, they pointed out was that if you see on the edges, I mean, here we don't see it, so that shows the limitations of a study like that. One of the things that they pointed out was that if on both the ends or one end of the core, tissue core, if you see epithelium, then that probably is not a fibroadenoma. Again, these are all soft findings, I mean, nothing is hard and fast here. And the reasoning for why in a Phyllodes tumor biopsy you would see epithelium at the end of the fragment is that in the, if you look at Phyllodes tumor, like, what impression we have, like, so these are like cystic lesions, right? I mean, finger-like processes and all. So when they do a core biopsy in the fragment, there is a greater chance of epithelium being seen at the edge of the tissue core if it is a Phyllodes tumor compared to a fibroadenoma. Fibroadenomas are very compact, so you are unlikely to see like intact epithelium at the edges of a tissue core. But as can be seen here, we don't see that, right? So, none of these things that they pointed out in the paper were 100%, but it was like, again, if you see mitotic figures in a core biopsy in the stromal cells, then that is unlikely to be a fibroadenoma. Having said that, we have always seen fibroadenomas which may show some mitotic activity. So anyway, but I think, I mean, this highly cellular kind of lesion, where you see expansion of the stroma, and then the infiltrative characteristics. So it's probably not a good idea to call something like this in the core biopsy as a fibroadenoma. So can we call this a Phyllodes tumor? I think a good compromise on a core biopsy is to use the generic term fibroepithelial lesion and then comment on it. What are the things that you see that are worrisome? Mitotic activity, if there is any stromal overgrowth, you can say that, cytologic atypia. Certainly if you see necrosis, I mean, that is cannot be present in a fibroadenoma unless it has undergone infarction. So you can comment and then favor based on your overall assessment what you are favoring, and then recommend like excision if it is fibroadenoma. If that is what you are favoring, then probably there is no need for excision. At Memorial Hospital, if we use the term fibroepithelial lesion on a core biopsy, then that is a buzzword for the radiologist to recommend excision. So we use that in a very strict sense. We don't use the term fibroepithelial lesion in a loose sense, like, that, oh, this could also stand for fibroadenoma. When we say fibroepithelial lesion here at Memorial Hospital, we are trying to tell the clinicians that this might well turn out to be a phyllodes tumor and that they should excise this. So in your setting, the connotations may be different. So it's always a good idea to write a note in comment as to exactly what you are favoring, or what is it something that you are worried about, and that maybe you need more material to make a definitive diagnosis, to be absolutely sure as to what it is. Now, if you use the term fibroepithelial lesion all the time, right? I mean, for just about everything, then there is a problem, because then you will end up with a lot of excisions, and then most of these excisions will be fibroadenoma. And you don't want to do that, right? Because that will affect your credibility. Now, years ago, I remember there was a funny situation. And, there is always a reason for all these things. First of all, the textbook picture of fibroadenoma that we see in the books, that is from the old studies, the old impressions of fibroadenoma. These are fibroadenomas from the time when fibroadenomas were palpable. They were like significant in size, and those kinds of lesions were always excised, and they usually had run their course. And oftentimes these would be kind of hypocellular, or they would be like, collagenized lesions, but these days, you don't see that picture of fibroadenoma. What you see is stuff that is detected on ultrasound. These are very small lesions, sub-centimeter lesions. And these may, even though they are fibroadenomas, they might be more cellular than what we typically see in our textbook pictures of fibroadenomas. So that, makes you uncomfortable, right? If you see something cellular, although it is a fibroadenoma, because it is cellular, you feel uncomfortable. And you call it fibroepithelial lesion. And then the surgeon excises, and then it turns out it's a fibroadenoma. So apparently, some years ago, I'm talking about many years ago, something like that probably was happening here. And I got an email from a surgeon who knew me personally. He said, Dilip, so whatever happened to the good old fibroadenoma? Don't we see that anymore? So, it takes some getting used to. Now, of course, we feel very comfortable in using the term fibroadenoma on core biopsies, even for lesions that may kind of appear to be somewhat cellular. And everything is fine. So, again, as I said earlier in our other discussions, there is always a learning curve involved. So we learn, right? I mean, it's always a good idea to try to find out what happened to something that you call fibroepithelial or an excision, whether it was a fibroadenoma or phyllodes tumor or something like that. And then as you go, you learn and you feel more comfortable. One of the things that helps in making this determination is the imaging findings. So what is it that the radiologist is seeing? So for example, if the radiologist tells us that this is a circumscribed nodular lesion and it measures 9 millimeters, right? And if you have multiple cores of tissue on your slide, pretty much it is possible that the radiologist has probably removed most of the lesion and sent to you in the core biopsy. Now, if the core biopsy is not looking that worrisome at all, although it may be a little bit cellular, what more are we going to see in the excision, right? I mean, probably less than what you are seeing in the excision. So there is no need to really, be hot under our collars in that situation. And it is fair to say that, this is not a worrisome thing and it's probably a fibroadenoma, and, just call it that you favor a fibroadenoma. On the other hand, if the radiologist or on the imaging report, it says that this is like a 5-centimeter lesion in a 70-year-old woman, I don't care what the biopsy shows. I want that lesion out. And I will show you examples where things may look like a fibroadenoma in a core biopsy, but even it may turn out to be like a malignant phyllodes tumor. A 70-year-old woman, you don't want, what are the chances that she would have like a cellular fibroepithelial lesion and that would be a fibroadenoma? No, that kind of thing is going to happen in a 20 or a 30-year-old woman. And there again, the lesion is probably not going to grow to be 5 centimeters. Although once in a while, fibroadenomas may become 5 centimeters in size. But we have to look at the context in making that determination. So therefore, like all other things in breast pathology, it's not a good idea to make a diagnosis in vacuum. You must have the clinical and the imaging findings at hand when you interpret core biopsies. Most of the mistakes that I have seen happening, they happen especially with regard to the fibroepithelial lesion. They happen because the pathologist did not have the imaging findings or the clinical findings. And I think that is something that I want to show in a PowerPoint presentation. So I will, I think, stop sharing and try to pull up my own presentation.
Yeah, that will be great. Thank you.
So let's try to pull this back in. Okay. So I won't show you all the slides. I'll just go to the most important stuff here because we will probably just take 1 hour to finish this talk. Okay. Okay, so here is an example that I want to show you. So this was like in a 70-year-old female, and this is only part of the core biopsy, and it looks kind of a fibroadenoma, right? I mean, except that it seems to be quite cellular. Now, probably the pathologist who made the diagnosis was not aware that this is a 70-year-old woman. And sometimes, you may know the age, but you may know, especially if you're not seeing this every day, you'll think, okay, yeah, this looks like a fibroadenoma to me. And so, yeah, this is a fibroadenoma. And so, in fact, this was called a cellular fibroadenoma. Now, again, at the time this biopsy was probably interpreted, it must have been a few weeks after the biopsy was done, because this was seen in consultation. So even the consulting pathologist called this a cellular fibroadenoma. But of course, unbeknownst to the pathologist, obviously this lesion was growing like mad, So again, somewhat higher power. For some reason, these cells don't look particularly worrisome, right? I mean, it would still be a fair game. Yeah, why not? This is the fibroadenoma. So it was called a cellular fibroadenoma. And I'll come to this word cellular fibroadenoma a little bit after we finish this story. Okay. So yeah. So the point I wanted to make is that this is the core biopsy lesion, and I'm showing you just in this inset a biopsy of a juvenile fibroadenoma. So there's not much difference, right, between these two. They look kind of alike. So to be fair to the pathologist, I mean, he or she had some reasons why that diagnosis was favored, except that this was not a juvenile patient. I mean, this was like a 70-year-old woman.
Mm.
So here is the diagnosis, cellular fibroadenoma. Guess what was happening to the patient? Because this patient, even with this diagnosis of cellular fibroadenoma, the surgeon had already brought the patient to the operation table. Because meanwhile, this lesion was growing wildly, so much so that in order to get around this lesion, the surgeon had to sacrifice skin. I mean, no fibro. Why would you need to remove skin for a fibroadenoma? I mean, the reason is this was not a fibroadenoma. Even at this power, you can see that this is something which is like effacing everything and growing like a sarcoma.
Mm.
And here you have somewhat higher power image. So this is a highly infiltrative lesion. And see, like, whereas in that biopsy, we were seeing all those ductal elements, right? Here we don't see any ducts. This is all spindle cell malignant lesion. This is what we would call stromal overgrowth. So when at 4x power of your objective lens, you don't see any epithelium or ducts. So that is called stromal overgrowth. If you see stromal overgrowth, that is certainly not a fibroadenoma. It probably is at least a borderline malignant phyllodes tumor. And also there was necrosis in this lesion. I mean, necrosis will never happen in a fibroadenoma. That is actually one of the bad prognostic indicators in a phyllodes tumor, presence of necrosis. So why did this happen? Why? See, you have to remember that especially in large lesions, sometimes the radiologist may not actually get into the center of the lesion. They may be at the periphery. So in phyllodes tumor, what you see in the center may be different from what you see at the periphery. So as you go towards the periphery, then the picture starts looking different. See again here, this is the center of the lesion. But at the periphery, now you are seeing the ducts. I mean, granted that these, even these cells look quite atypical. So nobody is going to call, if this is what was seen in the initial core biopsy, nobody would have called this a fibroadenoma. It would have been at least something atypical, But you can see the drift of what happens, and how mistakes happen.
Yeah, this is so scary. I mean,
Yeah.
I can see myself doing this mistake, and if it was not resected by, like, I don't know, God forbid, I don't know what would,
Right. So again, like when you go to the extreme periphery of that lesion, I'm talking about the lesion that we already are seeing, So this is what it was like, looking like at the very, very extreme edge of the lesion. So this is the highly cellular area. And then there is this tough kind of capsule. So if a radiologist biopsies this area, it's not going to show what is here. It will show you something that is not at all representative of the lesion. And so if you knew this was a 5 centimeter lesion or something, and it was growing over a period of weeks, then there is no reason for you to call it a fibroadenoma. I mean, I don't care what I'm seeing in the biopsy. I'm going to say that what I'm seeing here may not be representative of the lesion, and that they should take it out. See, I mean, this is somewhat so different. This is what so is similar to what was seen in that biopsy. And
still the stromal cells.
Unfortunately, when I saw this case, actually, it was few years after the, all that story had happened. I became aware of this lesion because the patient came with lung metastasis.
Oh.
So, although it is a rare thing, malignant phyllodes tumor, it does happen. And unfortunately, because it is so rare, none of us are that experienced. I mean, we will not see malignant phyllodes tumor every day, right? Even at Memorial Hospital, we see this only once in a while. So it's only from these illustrations that our awareness about how to handle these problems, increases.
I mean, I get fibroadenoma so commonly, and I mean, I have to rethink my approach to them in these cases.
Okay, so we will end. I'll just briefly go to another example. So this is a this is like a pleomorphic sarcoma, right? I mean, this is really wild. It's much wilder than what we saw in that earlier example. There are atypical mitotic figures, bizarre nuclei. So this is wall-to-wall high-grade malignant sarcoma or phyllodes tumor. The reason we can say this is phyllodes tumor is because at the periphery of it, we are now seeing this periductal, component, which will make this into a fibroepithelial lesion. But again, see how different the center of the lesion is from the periphery. And even if, I mean, if they had biopsied this area, right, you would never imagine that it was harboring something as ugly as this that is seen in the center. And if you go to the extreme periphery of that same lesion, the memory parenchyma gets compressed, and you will think that, oh, this is just some kind of adenosis or some benign fibroadenoma. And even these atypical looking cells, you may just dismiss them as some kind of stromal giant cells, right? So I don't want to scare you guys, but I mean, these are two illustrations that I always show our fellows and residents to just make this point that one should never make a diagnosis without knowing what the imaging findings are, what is the age of the patient, how big the tumor is, was this growing, because they will tell you sometimes that this lesion has been growing in the last 2 months or something like that. If that information is available, then that becomes very important. Okay, so this is the last slide from that case. See, this is that pleomorphic sarcoma, right, smack in the middle of the tumor. And as you go, this is the tough capsule. And now you can imagine why the radiologist might not get access to this lesion, because the needle may just bounce off this capsule. And you get a totally unrepresentative picture on your core biopsy. Again, this will happen rarely. Most often, a radiologist will manage to find the core, because they are interested in getting to the core of the lesion. I mean, they are not satisfied if they just get the periphery. But again, depending on the expertise and experience level of the radiologist, the sampling could be different. At Memorial Hospital, our radiologists, they have a greater level of awareness. So they will probably sample these lesions much better than maybe outside in the outer setting. Okay.
Very good learning cases. I am really good cases.
Okay. Yeah, I mean, this is the whole advantage of doing sessions like this.
Yeah.
So the take-home message from this whole discussion of phyllodes tumor or fibroepithelial fibroadenomas is that get all the information that you possibly can before making a firm diagnosis, especially if you are not doing this, every day. So here is another example of a phyllodes tumor. So clearly we are seeing this, telltale.
I'm not seeing your path outline screen.
Oh, you're not seeing it, right? Because right.
Yeah.
So let me, yeah. I'll have to stop share and then go back.
Mm-hmm.
Can you see now?
Yes.
Oh, okay. Okay. So let's, so this is another example. This is an excision of a phyllodes tumor. And, clearly we know this is phyllodes tumor because we are seeing this finger-like, leaf-like, structures. And that is how the term phyllodes tumor actually began. I mean, that, there were like phyllodes tumor carried something like 80 names, or some 60 names or something like that, So there was quite confusing, the literature, the older literature. I mean, terms like cystosarcoma phyllodes and phyllodes tumor and a lot of other things, terminologies were used. So now of course, we only have one name for it. So see how the picture is different. So that is another feature of a phyllodes tumor. Unlike a fibroadenoma, there will be the morphology will be quite different in different areas.
Mm-hmm. Also show us benign, borderline, and malignant, and to differentiate.
Yeah, so we'll see as we go along.
Yeah.
So clearly, this is very cellular, right? I mean, this is a very high degree of cellularity. And if you go to the edge, it's again, beginning to show infiltrative characteristics. It is entrapping fat.
Mm-hmm.
So something like this, so how do we address this, right? So what are the features of benign phyllodes tumor, and how do you distinguish benign from borderline and borderline from malignant? So, I mean, one would have to read the definitions in, textbooks and WHO and all that. I don't know if I have, I mean, I can just tell you briefly that for something like this, when you have, obviously, there is marked stromal expansion and high degree of cellularity, and you would have to count the mitotic figures here. Mm-hmm. But given that it is already trying to infiltrate, I mean, this is clearly a worrisome lesion. Although for most part it appears to be somewhat circumscribed, but it's clearly trying to infiltrate. We can see fat. Mm-hmm. So something like this is like at least like a borderline phyllodes tumor. I wouldn't call this overtly malignant. Mm-hmm. For that, you need to see stromal overgrowth. So you have bigger areas where there is no epithelium at all, and it would be even more infiltrative than this. So why does it matter really? That distinction between malignant, borderline, and benign. I mean, in terms of the surgery itself, between borderline and malignant, there is not that much of a difference. They will, nowadays nobody does mastectomy for phyllodes tumor unless it's like a really, really huge lesion. Mm-hmm. And it has become so malignant that it is infiltrating the skin and all that. So generally they will do a lumpectomy. And as long as they get good margins, it really, the surgery is done, whether it is malignant or borderline. or benign. If the margins are positive or they are very close, then they will have to go back to get clear. Whether it is malignant, borderline, it doesn't matter. They will still have to go back. The difference only is in terms of the prognosis. So if it is a malignant phyllodes tumor, then clearly it's a sarcoma, right? So it has to be treated like a sarcoma. So these patients will be at risk to develop metastasis. Borderline phyllodes tumor, the chance of metastasis is rare. The only worry is that the potential to recur is high. Even with negative margins, there is a chance that something like that will recur. And why that happens? So for that, let's go back to my PowerPoint.
So there is no radio or chemotherapy for phyllodes, no?
For borderline and benign, obviously there is no role for any, any further treatment. Surgery is the only thing. And then they just have to do close follow-up. Because even if when they recur, borderline phyllodes or benign phyllodes, for quite a while, they will only recur in that same fashion, like they will recur as borderline or benign. The progression, while theoretically can happen into a malignant one, it takes a while. So, there is nothing to be done immediately. For malignant phyllodes tumor, which are like, especially the high-grade ones, they are sarcomas. I mean, it's best that they're referred to a sarcoma clinician. And they will decide. I mean, I don't know, the state of the art keeps changing. So whether there is any role for radiation and all, I don't think that I would like to comment on that. I would let clinicians decide that. But obviously now you are dealing with a sarcoma.
Right.
Okay, so I'll stop sharing and then go back and then we will share again. Okay, so so what are the predictors for local recurrence? So there was a study done here at Memorial some years ago. This was quite a large study. At the time, this was one of the largest studies on phyllodes tumor. So these are the determinants of local recurrence in that study. So for example, positive margins, right? I mean, obviously, if you have positive margins, then this is going to recur. There is this term fibroproliferation, and I'll come to that in a minute. But if you see necrosis, then obviously this is a lesion that has malignant potential, right? So it is likely to recur. So marked stromal cellularity is something. So all of these point to something that has, a proliferative potential, and therefore the chances of local recurrence are high. Again, high mitotic activity, And there is this thing about prior history of fibroadenoma. So why would this increase the chance of recurrence? I mean, it's not very clear. I think what it points is to the fact that maybe somebody who has so-called fibroadenomas, they have multiple such changes in their breast tissue. And some of these might have the potential to kind of, grow subsequently. So although the margins may be negative, can I take this phone? I'll just mute myself.
Yes. Sure. Please go ahead, please. I think you're looking into how to unmute yourself. I will send you unmute. If you're asked to unmute. Okay. Did you get a pop-up?
Okay, now you
Yeah.
can hear me, right?
Yes.
Okay. Okay, so yeah, so
So this was, I have a question. So this was when before they were designated as benign, borderline, and malignant, this study?
yeah, so this study is about all phyllodes tumor. What is the chance of local recurrence?
Yeah.
So obviously, I mean, the cases were diagnosed as benign, malignant, and borderline, but this is like going into what are the risk factors for local recurrence. So obviously, when you have something like necrosis, right, that is already a malignant phyllodes. That would be a characteristic of a malignant phyllodes tumor, and you would expect that a malignant phyllodes tumor will carry a higher risk for local recurrence. It will also have a risk for metastasis, but just like any other cancer, it will also carry a higher risk for local recurrence. But when it comes to benign phyllodes tumor, the chances of local recurrence are rather low, especially if the margins are negative. But obviously, I mean, a surgeon would probably not leave this positive margins, but I think this was a retrospective study. And what they found was that if the margins were positive, then regardless of whether it was benign or malignant, the risk for recurrence was high. And that is, I mean, that is logical, right? If you leave positive margins, then even like a fibroadenoma might grow, right? I mean, because, although it has got a low potential to proliferate, a fibroadenoma grew because it had some growth potential.
Right.
So am I making it clear?
Yes, you are.
Yeah. Now, I was talking of, so all of these things, are telling us that there is a proliferative potential. Some of these obviously are malignant, but even a borderline or a benign, I mean, a benign phyllodes tumor probably will not have more than 5 mitotic figures. So it is something like this situation is already probably a borderline phyllodes tumor. So even if a surgeon has clear margins, he will tell the patient that, you have a borderline phyllodes tumor. And although the chances of this thing metastasizing are quite low, we need to follow you up closely because there is a chance that you will come back with recurrence. So similarly, the history of prior fibroadenoma. So that in this study was discovered as a risk factor. And so I was just trying to question why would that be a risk factor? I mean, what it tells us is that a woman who has phyllodes tumor, and if she has a fibroadenoma removed previously, so first of all, we don't know, right? I mean, this is a retrospective study. So first of all, you have to ask yourself, how reliable was that diagnosis? I mean, unless you have seen that slide, it would be difficult for you to say that, yeah, there is a history of fibroadenoma, but you don't know whether that was really a fibroadenoma. It is quite possible that what was called a fibroadenoma may not have been a fibroadenoma, first of all. It also tells us that this woman's breast probably has some such lesions, which are fibroadenomatoid, and therefore they probably have some growth potential. And in future, those similar foci have the potential to grow again, and they may present as recurrence. Okay? Does that make sense?
Yeah, it does, definitely.
Yeah. Okay. So let's, so obviously I'm just trying to show, like, I mean, if it is a positive margin, high cellularity, necrosis. So this is what is called as fibroproliferative foci. So in this paper, unfortunately, they did not have illustrations of that. So these are some illustrations that I just, created as to what they might be suggesting. Because many times, in cases of phyllodes tumor, you will see at the edge or at the periphery of those lesions, those big lesions, you will see a few millimeters away, such discrete foci, duct with highly cellular. Some of this may actually look similar to the lesion itself, but these would be like satellite things, So, so it is quite possible that these kind of satellite things are also present outside of the field of the surgery. So even if there is a negative margin, these patients are at risk to locally recur because they have in their breast these foci which are subclinical and microscopic. But over a period of time, after a few years, something like this will become clinically evident, and they will present as maybe phyllodes tumor. And because they generally don't progress that rapidly, they will grow again like in the same way, like maybe benign phyllodes or borderline phyllodes and all. So, but when does one start worrying about these? So that is not quite clear. Because sometimes you may have satellite kind of nodules which may even look something like this. So should one worry about it? Is this a risk factor? I mean, I don't know honestly, but sometimes they may look like PASH actually. So obviously one need not worry about something like this and not. But again, this is only one study where they have commented on something like the presence of fibroproliferation and things like that. But that is something interesting. I'm not just recommending that if you see something like that, you should make a big deal about it. But that will give you some rationale as to why these cases, these patients have the risk for local recurrence. Okay.
Margins assessment in these cases, like, I mean, I personally have seen phyllodes only in, I mean, I personally had one case in my residency, and otherwise I've seen those in just study sets. But margin assessment, I mean, if there is stroma over there in the margin, how do you make distinction whether it is stroma from phyllodes versus normal benign stroma?
Yeah, I mean, that would have to be your morphologic judgment, whether the stroma is neoplastic looking or not.
But like the edge that you showed, like,
Yeah.
as you said, that the edge can be really benign appearing too at times.
Yeah, yeah. I mean, so, I mean, I see what you are saying, but, that close to the lesion, it would have to be a positive margin, unless it's like a totally collagenous, benign breast parenchyma or something. That would be like a negative margin. But when you are grossly looking at the lesion, right? So when you have the gross specimen and you are inking it, you will get a sense of how much normal breast tissue is around the lesion.
Right, right.
So I would go by that actually. But that's a good question. So, okay, so I'm going to stop sharing here and let's go back. Okay, let me begin sharing again. Okay. Okay, so here, for example, I mean, here is the ink, right? So
yeah, if you have fat, then
so if the ink was here, obviously that would be a positive margin, right?
Yeah.
Okay. Okay, so this is a good example, right? So now although we do see some infiltration here, quite a lot of infiltration. So, but this lesion looks less worrisome, right, than the previous
Yeah,
one, just
yeah.
to our eyes, because we see quite regular distribution of the ducts. There doesn't seem to be certainly any suggestion that there might be stromal overgrowth, but it does have infiltrative characteristics. So what does one do? So again, one thing we have to remember is that the sampling of these lesions has to be adequate. So at least, like, if it is a 5 centimeter lesion, you should have at least 5 to 6 slides from that, and not just 1 or 2 slides, because the picture can be very different in other areas. But
so is the infiltrative nature of these lesions enough to, like in the
call it benign versus borderline, or so
malignant.
so that is not very clear. I mean, if you look at the WHO and all that, nobody will tell you that this is one thing that helps you distinguish this from that.
Right.
So you have to look at the totality. So
Right.
none of us know sufficiently about these things to be absolutely certain with one criteria. So you would have to look at everything. So infiltrative means certainly this is something to worry about, right? So now I'm worrying. At least it is Phyllodes tumor, right? I mean, it's not a fibroadenoma. So then I'm looking at the cellularity, the cellular atypia, how mitotic it is. If I don't see any mitotic figures, if there doesn't seem to be cytologically atypical, doesn't seem to be that, there is like a lot of stromal cellularity somewhere, or a lot of foci of expansion, then simply because it is infiltrative, I'm not going to call it borderline, right? I will just say benign. But benign can also be infiltrative, and it definitely carries some risk for recurrence. But the chance of recurrence is lower than borderline.
So in case of excisions, if we have bland stroma and just the infiltrative pattern, I mean, is it wise to just call it fibroepithelial lesion and then mention that there is infiltrative pattern? And,
right. Yeah, because that is absolutely the way to do it. Because when we say infiltration, you have to be sure that it is infiltration. This is probably not infiltration. This is just collagenous stroma, right? I mean I mean, even here there is collagenous stroma, right? And there is fat. So, but we don't say this is infiltration. This is just normal fibroadipose tissue, right? So, so you have to be sure of what you're talking about.
Yeah.
So, I mean, this obviously to me suggests that this is, I mean, tumor that is entrapping fat, right?
Right.
Yeah. So there is no easy answer to all these questions, So I mean, clearly this is tumor that is infiltrating fat.
Yeah.
But if you begin to worry about this kind of thing, but that is not infiltration. This is just normal fibroadipose tissue,
Right.
So another core biopsy.
This one is easy.
So now, this is the core biopsy, but here you are seeing, right? This is malignant. I mean, these cells are not benign. So this is enough to call malignant Phyllodes tumor, regardless of what else you are seeing in the specimen. You cannot have this kind of malignant looking cells, in a benign thing. So, but, so there will be some cases where you can call on a core biopsy malignant Phyllodes tumor. You don't have to agonize much. So what is this now? So this is very interesting because this is growing like we are seeing ductal lining here. It seems to be somewhat of a big duct or something, which is stretched on the edges of this lesion. But the lesion itself is showing a lot of glands, right? The stroma is not that much. So obviously it has to be something fibroepithelial. But the stroma doesn't seem to be doing much. Yeah. So again, we only have one slide here. So of course, obviously, we need to have the whole specimen and a lot of slides and make the determination whether it looks like this everywhere. And again, if there are no mitotic figures, doesn't seem to be very atypical, then there is no need to worry too much about something like this. You can just call it like a benign fibroepithelial lesion and just leave it at that. I mean, what are the chances that something like this is going to grow? Probably very low, right? So, because the stroma, whatever we are seeing, does not seem to have the potential to push aside all these glands.
Right. There is no infiltration. There is no.
Yeah, there is no infiltration. Activity. I mean, if the stroma had the potential to proliferate, it would have pushed all these glands,
Right.
Right. So we have to use our, some kind of common sense and, and then try to make assessment. So again, this is somewhat of an adenosis, something kind of a thing, right? So this will masquerade as anything, many times. I mean, in the background itself, there seems to be a lot of this kind of, large lobules and all. So I'm not even sure what exactly this is. I mean, certainly you don't want to call something like this as Phyllodes tumor or something.
Yeah.
It could just be some weird adenosis or, tubular adenoma or something like that. Okay. Okay, I think now we'll stop here and we'll reconvene tomorrow.
Time flies when you're talking.
Oh, that's good, right? So,
thank you very much. It was such a great session.
Oh, thanks. I'm glad that, you're enjoying it. Okay.
Yes, definitely. All right. Thank you very much.
Sure.
Yeah. Bye-bye.